Good morning, everyone, and welcome to today's program. Breathe Finally, Practical Proactive Approaches to Receive Personalized Care for Your Nasal Polyps. My name is Sanaz Aftakari. I'm a Vice President at the Asthma and Allergy Foundation of America, or AAFA. I'm joined today by Dr. John Basso and Dr. Noam Cohen. I'm also joined by Missy Canty, who's a person living with nasal polyps. Today's program is presented by Medlive and the Asthma and Allergy Foundation of America. It's supported by Regeneron Pharmaceuticals, as well as Sanofi. So for today's program, please ask questions under the box in the video. We're unable to answer questions about your case specifically, but we encourage you to bring those questions to your doctor. There's also a section on event resources under the video as well. Here are our disclosures. And here's the agenda for today's program. So in the first section, we're going to focus on these two first bullets. Why do nasal polyps happen and why do they come back in some cases? And what are severe refractory nasal polyps? In the second section, we'll talk about treatment options. And in the third section, we'll talk about how to be engaged for optimal treatment. And with that, we're going to kick it off with a poll before we get started. So if you have nasal polyps, which of these conditions have you also been diagnosed with? A lot of times they come hand in hand. So select all that apply in your case. Option A is allergies. Option B is asthma. Option C is eczema or atopic dermatitis. Option D is eosinophilic esophagitis or EOE. Option E is chronic rhinosinusitis, or option F, not applicable if you don't have any of these. And Missy, I'd love to bring you in here. Do you have any of these comorbidities?
Yes, I do, Sanaz. So I also have allergies and I have asthma and I've had eczema since I'm a child. And I also have chronic rhinosinusitis, also as well as low vitamin D.
Yeah, and we hear that a lot, actually, that some of these conditions, come hand in hand. A lot of people managing nasal polyps also have allergies and asthma, for example. And that's actually the most common response we got for this poll. And actually, of those two, allergies came in at the top spot. So very common to hear. Again, they are comorbidities and related conditions. So with that, we'll get started with the first section. We'll talk about why do nasal polyps happen, and in some cases, why do they keep coming back? With that, Dr. Basso, I'll hand it over to you.
Thank you, Sanaz. Many patients say, how do I know if I have nasal polyps? Well, the truth is that most people don't know. You may think you have allergies, you may think you have a cold, you have this chronic congestion, the cold that never goes away, and stuffiness, runny nose, postnasal drip, sinus pressure, headaches, loss of smell. And this starts lasting more than 12 weeks. It becomes what we call chronic. And so you may, on very infrequent occasion, be able to see extremely large polyps inside your nostril, but the truth is that they're only really visible in most cases to a doctor. And the most common doctor to diagnose them would be an ear, nose, and throat doctor who is going to use an endoscope that you could see in this photo, looking into the nose with a fiber optic light. Some allergists, immunologists will also pick this up on examination. Infrequently, primary care doctors will, but for the most part, they often refer over to specialists when they suspect that polyps may be forming. You mentioned that co-occurring or comorbid conditions are frequent in patients who have nasal polyps. Nasal polyps are technically defined as a form of chronic rhinosinusitis. There are two types of chronic rhinosinusitis, those with nasal polyps and those without nasal polyps. The type with nasal polyps is referred to as CRSWNP. And so we're going to refer to that in the program if you see that abbreviation. Asthma, as was mentioned, is a frequent accompanying condition, and having asthma and CRSWNP actually means that patients will have more aggressive inflammation, and one condition makes the other condition more severe. Allergic rhinitis is very frequent as well. Nasal allergy, allergic fungal rhinosinusitis, or AFRS, is a condition where patients are allergic to mold. And when they develop a severe mold allergy, the mold gets inhaled into the sinuses and causes a chronic inflammatory allergic reaction that eventually results in polyps and excessive thick mucus. AERD, or aspirin-exacerbated respiratory disease, which is a triad of chronic rhinosinusitis with nasal polyps, plus asthma, plus a respiratory allergic sensitivity to medicines in the aspirin family, or nonsteroidal anti-inflammatory drugs, usually develops in adulthood. Eosinophilic esophagitis is growing in popularity in terms of diagnosis. We're finding more cases of this. This is a inflammatory reaction within the esophagus, most often caused by an allergy to food that presents with patients having difficulty swallowing in adulthood. Gastroesophageal reflux disease, and cystic fibrosis, which is a genetic condition that causes chronic infections and changes in the mucus that also result in nasal polyps and usually present earlier on in life. So it's really important that you manage your nasal polyps to reclaim your quality of life. For a lot of patients, it takes a long time to get a diagnosis. I mean, I think that they may have these symptoms for a long time before they go to the right person and someone says, hey, you know, you have chronic sinusitis with nasal polyps. And so the quality of life that these patients experience is quite significant, quite severe. And it's been likened to conditions like COPD, asthma, diabetes, congestive heart failure. So the loss of smell is often the worst part of what patients have to deal with. They seem to be most affected by this in terms of their emotions. Depression and anxiety are common in patients who lose their sense of smell. So it's important that you manage your nasal polyps so that you can improve your quality of life. And so new treatments offer hope for patients to get better and have their better quality of life. And that's what we're talking about here today. So let's watch a clip from Jack. He's a person with nasal polyps. He'll tell us about his symptoms and how he received his diagnosis. Jack?
Yeah, so it's been about 4 to 5 years now since I found out that I've had nasal polyps, and I still deal with a lot of congestion. There's just not a real clear path for me to breathe up in there. Like, it's like physical kind of blockage. Every now and then I'll get really bad sinus headaches. I call them sinus migraines. I know that's definitely not a technical term, but just like a lot of really sharp pain up in here. Still every day is just a lot of mucus that I'm constantly blowing my nose throughout the day, and just kind of constant pressure, like bending over to like pick something up. I can kind of feel everything moves to the forefront of my forehead or like my cheek sinuses. So it's kind of been the same symptoms the whole time. Just they'll go through waves of being more severe or, you know, not quite as bad, depending on if I've recently had a sinus infection or if it was recent after a surgery or something like that. So before receiving my diagnosis, I really had only seen my primary doctor, my primary care, like pediatrician at the time. And then I went to the ENT specialist who I'd seen earlier in my life for other sinus and ENT related stuff. And it wasn't actually until after a second kind of procedure with him that he found polyps. And because before it had just been thought, after I did a bunch of CT scans and, you know, he'd scoped up inside my nose and stuff, and it was just like a ton of junk, for lack of a better word. And so we did 2 balloon sinuplasties, but it wasn't until the second one that he had found polyps. And then we kind of had to go from there after figuring out that was the main issue.
Thank you, Jack. So how do nasal polyps really form, and why do they keep coming back? Well, in most patients in the United States, nasal polyps are thought to result from this chronic inflammatory reaction called type 2 inflammation, which involves a number of cells called mast cells, eosinophils, and a number of other aggressive inflammatory chemicals that are released from these cells. The tissues break down usually the lining of the sinuses will break down, and then you get this acceleration of the inflammatory process. This can be accelerated. The lining can be broken down by microbes that grow, or by pollutants, allergens. Once that barrier is breached, then the inflammatory process just takes off. And so what results is you get this swelling, and inflammatory cells and tissue fluid get underneath the lining of the sinuses, and they form these grape-like growths that protrude into the passageways, and these are the polyps. And although medications can shrink polyps and surgery can remove them, but the underlying inflammatory process never takes a holiday. It just continues. So that's why without a long-term treatment program, and without the realization that this is a condition that will continue, they will come back.
Thank you, Dr. Basso. And with that, we'll go into our second polling question. So please answer this question. If you've taken in the past, or if you're currently taking intranasal corticosteroids, what's been your experience with those? And option A is they treated the rhinosinusitis. Option B is that the nasal polyps shrank and they didn't grow back. Option C is that the nasal polyps shrank, but they did come back. Option D is that they didn't work for you at all. And option E is not applicable because you haven't taken intranasal corticosteroids. Ms. C, I'm curious how you'd answer this question.
So in my case, when I did take intranasal corticosteroids, my nasal polyps did return, and I did the sinus rinses that contained the steroids as well as the spray. And in both circumstances, they still were there.
Yeah, and we do hear that story as well. And I know that Dr. Basso and Dr. Cohen will share too, that in a lot of cases, they might shrink and come back. For this poll, the majority actually answered option D, that they didn't work for me at all. So, there are other options out there, and we'll get into those as well. And with that, I believe I'll pass it back over to you, Dr. Basso.
It's coming over to me. So,
over to you, Dr. Cohen. My apologies.
That's okay. So I'm going to talk a little bit about the management, both on the medical standpoint and the surgical standpoint. And as we heard, the workhorse really behind treating this inflammation are anti-inflammatory steroids. Traditionally, this has been with intranasal corticosteroid sprays. In addition to the sprays, we have to remember that this disease is really driven by the environment. And so what we want to try to do is wash out whatever the insulting agents are that we're breathing in by washing out the nose, or something called nasal toilet. And we're not talking about small volumes of saline. We're talking about large volume of saline, like a neti pot or a sinus rinse bottle. And the recommendation is that you flush out your nose and you perform this at least twice a day. Well, that's a little bit of a tough pill to swallow. It makes a mess. It's a lot of effort. I try to sell it to patients with chronic sinusitis that it's like brushing your teeth. You wouldn't think about leaving the house in the morning without brushing your teeth, and hopefully you wouldn't think about going to bed at night without brushing your teeth. You need to bring this into your daily regimen for the management of your nose. So in addition to the saline, and in addition to the steroids, that has been the mainstay for many, many years. The problem with the sprays is the steroids are only as good as where they get to. And these nasal steroid sprays are not really designed for treating chronic sinusitis or nasal polyps. They're really they're designed to treat allergies, and they really only get into the first inch of your nose. So over the last 10 years, there's been a little bit of a paradigm shift in how we've combined these two therapies. And Missy alluded to this by taking steroids and putting them into the irrigations. And what that does is it delivers more of the steroid deeper into the sinuses. And that has improved the control of polyps by getting the steroids deeper in. When this topical anti-inflammatory approach doesn't really control the polyps, we can then scale it up to using systemic steroids or pills. And these are usually very, very effective. The problem is that they have a lot of side effects: weight gain, mood swings. Long-term, they can have really catastrophic complications such as hip fractures, glaucoma. And so we typically use systemic steroids or oral prednisone pills in short bursts. And so that's really the mainstay of the medical therapy, in addition to trying to control the environmental components. When that doesn't work, from an otolaryngeal standpoint, the next option is to go in and surgically remove these polyps. And so the idea behind functional endoscopic sinus surgery is to not only remove the polyps, but to restore the function of the lining of the sinuses such that you clear mucus normally. And the way that I like to kind of sell the surgery to the patients is that if you think about your sinuses as an egg carton, what we're trying to do is go in and remove all the little divisions of that egg carton such that you can still fit 12 eggs into that egg carton, but they roll around. And the eggs are really the mucus. And what you're trying to do is restore the ability of the mucus to drain, because when the mucus doesn't drain, that's what's really driving a lot of the symptoms that Jack described in the video, that pressure. Just like every surgery, there are risks involved, bleeding, infection. The ones that are specific to sinus surgery is getting out of the cavity, either up into the head, into the brain, or into the eye. So there could be orbital trauma and there can be intracranial trauma. They're not common, but they do happen. Recovery from the surgery is usually about 1 week off of work, and then the healing process is somewhere between 4 and 6 weeks. We usually recommend taking it easy for about 2 to 3 weeks. It's expected that there will be bloody drainage over the first couple of days. And then the problem with patients that have polyps, because it's not really a surgical disease, it's an environmental disease, oftentimes the polyps come back. And so we've kind of refashioned the way we think about our surgery, which is giving access to those irrigations. And so we can put more and more medications, the steroids or antibiotics, into the irrigations. And the point of the surgery now is to really open up the cavity so that the irrigations have more efficacy in treating that inflammation.
All right, let's jump into another audience polling question. So let us know, when were you diagnosed with nasal polyps? And in that case, when did your doctor explain what to expect from treatment? So option A is yes, you fully understood what to expect. Option B is somewhat, you didn't anticipate having to try so many treatments. Option C is no, you were surprised at how difficult managing your nasal polyps would turn out to be. And Missy, I know you alluded to this earlier, you saw a different ENT, but can you tell us a little bit just about your diagnosis and the process to get there?
Yes, so I was diagnosed in 2016, and at that time, again, there was major flooding within my area, and I had the allergy issues with severe mold allergy. So the first doctor, and with me, I'm choosing someone I didn't anticipate having to try so many treatments. So the first doctor did not explain thoroughly what polyps were. He only stated that I did have to get surgery and that if I didn't, the polyps would go into my sinus cavities and possibly protruding outward, causing a disfigurement in my face. The second doctor explained more thoroughly on what would occur during the surgery and the effectiveness of the surgery. He also gave me the options of oral steroids prior into me opting into the surgery. So I knew at the time of me being diagnosed that polyps could be recurring with the treatments that were available to me at that time.
Yeah, and we'll talk a little bit more later in the program about just finding the right care team to help you through the process, and that can make a big difference as well. So for this poll, the majority answered somewhat, option B, somewhat. They didn't anticipate having to try so many treatments. And with that, we'll just roll into the question and answer, the first Q&A for the program. Missy, I'll start with you. You talked a little bit about the diagnosis process, but can you tell us a little bit about how you were tested specifically for the nasal polyps?
So with me, my ENT actually used a certain tool to look into my nasal cavity, and he actually was able to see it. Also, before I went to the ENT, as stuffy as I decided to look myself in the mirror, and I noticed that I had it almost seemed like it was mucus, but the more I blew my nose, this mucus that I could see was not, leaving. So that's when I, went to my primary doctor, who recommended me to go to the ENT, and then the ENT, looked inside my nostril and was able to see that I had a nasal polyp that he could have visually seen at the time.
Yeah, so it's a matter of getting to the right doctor and making sure that they're running all the right tests and kind of working with you to make sure that diagnosis is correct. So the second question, I'm going to go over to you, Dr. Basso. You mentioned type 2 inflammation as one of the causes for polyps. Are there any other causes you'd like to mention?
Well, I mean, there are three types of inflammation. There's type 1, 2, and 3. In the United States, about 87% of cases are type 2. Type 1 and type 3 inflammation are usually more associated with infection or responses of other cells like neutrophils. For example, patients with cystic fibrosis are colonized with certain bacteria because their mucus is abnormally thick. And so those inflammatory microbes can lead to the formation of polyps. If you go to the Eastern world, like for example, in rural China, probably only about 10% of patients have type 2 inflammation. And then if you go into Beijing, it's about 25 to 30% and rising. So the westernization of life, sort of our form of life, probably has added to, and Noam mentioned that the environment is a trigger. The environment is often the reason why type 2 inflammation gets stimulated. Changes in the environment, or even changes in things that people are exposed to in their local microenvironments, their own little homes, can be the start of what brings on an inflammatory reaction that just continues. But again, there are more polyps in the Eastern world that are associated with infection and microbes like bacteria and viruses than there are here in the United States.
Thank you. Let's do two more questions. And Dr. Basso, I'm going to stick with you. We talked a little bit about the connection between nasal polyps and other comorbidities like asthma and allergies, but can you tell us if nasal polyps actually contribute to the symptoms for asthma and allergies?
Oh, absolutely. I mean, there's a connection between the upper and the lower airways. We call it the unified airway disease or unified airway disorder. And that's the same chemicals and inflammatory release of certain, what we call cytokines, which are what the cells produce, are found in the upper and the lower airway. And there are also reflexes between the upper and the lower airway. So when the sinuses are bad, and that means filled with polyps and inflammatory tissue, you'll always see a reaction in the lower airway in many patients. And that means worsening of their asthma. Same as if the asthma is getting worse, it seems like it makes the patients with more severe asthma have more difficult to treat polyps. So there is a relationship that occurs within the immune system. And with all these other conditions, for example, eosinophilic esophagitis, there's also abnormal type 2 inflammation occurring there. So, and as there is in atopic dermatitis. So you'll see a lot of these other comorbid conditions occur because they have that common thread where there's same types of cells, same types of chemicals being released by the cells that are found in all of these inflammatory comorbidities. And so that's where the overlap is, and that's where the connection is.
Yeah, so we hear that too at the Asthma and Allergy Foundation of America. Somebody will come to us with questions about one of those conditions, mention in passing they have another one, and are kind of surprised to hear that they're all kind of connected in the body. So it's really helpful to walk through that. Let's do one more question, Dr. Cohen. I'm going to kick it over to you. So for people who are maybe a little scared of surgeries like myself, I'm going to put myself in that camp right there. How do you remove the polyps? And do you, are the people who are going through the surgery, are they asleep? Do you cut out the polyps? Can you talk us a little bit through that? And I know we talk about the surgery a little bit more, but maybe just touch on it here a little bit.
So there's several techniques to working in the sinuses. For nasal polyps specifically, they have to be removed. And there are certain different devices that we can use. You can either go in and you can snip them and pull them out. There's also something called a microdebrider, which is literally it's a suction that has an oscillating blade. And so what it basically does is it sucks the polyp into this tiny little hole, and it slowly kind of nibbles away at it. in a very controlled fashion. So you can basically work at the very bottom of the polyp and work your way up. And that way you can also try to minimize the amount of bleeding. In today's world, the majority of sinus surgery is done asleep. There are people who will do this in the clinic under some local sedation or some topical. There's another intervention called balloon sinuplasty. And what that does is that opens up the sinuses, but it doesn't actually remove or treat the polyps. And so oftentimes patients will say, well, can I just have it ballooned? And in nasal polyps, balloons don't really work. So if you have the type of infection that Dr. Basso was talking about, the type 1, that is an infectious process, and the mucus just simply isn't draining, but you don't have polyps, balloons can work. But in the setting of nasal polyps, the balloon sinuplasty is not very effective. And so, yes, we go in, we remove them. And the idea, again, is to make a big cavity so that the anti-inflammatory therapies that we put in the irrigations can access all the nooks and crannies of the sinonasal labyrinth or cavity.
Okay, thank you. And I think that's a good transition to the next section. I know Missy has some experiences with surgery as well that she'll share with us. So over to the second part here, we're going to talk a little bit about severe refractory and recurrent nasal polyps after surgery. So this is about the treatment options. And with that, we're going to hear a story from Jack about his recovery from surgery.
I would say the last couple surgeries that I did, the recovery period was somewhere from 2 to 3 weeks that I was dealing with a lot of, especially the first week, like bleeding and discharge. And I wasn't allowed to do any sort of strenuous physical activity for, I believe it was 20 days. And a lot of rinsing was necessary and not just encouraged. And it wasn't until about a month after surgery that I could actually breathe and not be impacted by polyps or just all the leftover blood and stuff from the surgery. That was, I would say, a month to 2 months was kind of the period where I actually was able to feel some relief from surgery before they started growing back.
All right. Thank you, Jack. Time for another poll. So if you have had ESS, and again, that stands for the endoscopic sinus surgery, about how long was it before your nasal polyps came back? So option A is 1 to 3 months. Option B is 4 to 6 months. Option C is 7 to 9 months. Option D is more than 9 months. Option E, they still have not come back, thankfully. And option F is not applicable because you haven't had the sinus surgery. So Missy, I know you've had some experience here. Can I ask you for your story here?
Yes, and I choose D, more than 9 months. So I would say it was about 1.5 years, and then my nasal polyps did come back. Similar to Jack, when I had the endoscopic sinus surgery, the same day of my surgery, I did have bleeding, and I had to do a lot of the oral flushes. And it took about, I would say, 3 to 4 weeks. I know I couldn't lift anything. I'm heavy. And at that time, I couldn't lift up my child. So it took over about a month period for me to actually heal and go back to work. My particular type of job, I am a customer service representative, so I do a lot of talking over the phone. So I couldn't, go right back to work after I had my surgery. I did have a series of oral steroids about every 3 months after the surgery. And it had gotten to the point where the oral steroids as well, they only lasted a month. So the endoscopic sinus surgery was not too much successful in my situation.
Yeah, and we know those results differ from person to person. In our poll here, the majority answered 1 to 3 months, but we have heard stories like yours where it takes more than 9 months and then everything in between as well. I'm going to kick it over to Dr. Cohen to talk to us a little bit about severe refractory and recurring nasal polyps.
So as we heard, these things, the polyps usually come back, and that's because it has to do with the environment. So one of the options is to change location, right? If you were to move to the Southwest, chances are the polyps will come back, but often that's not really consistent with what you're doing. The way that we usually look at refractory or recalcitrant nasal polyps is based really on the patient. One of the things that we didn't talk about is radiographic imaging. Many of the individuals with chronic sinusitis and nasal polyps will have CT scans. And polyps will show up on CT scans, and as treating physicians, we often look at the CT scans to see if the polyps are coming back. But from my practice, I'm not treating a CT scan, I'm treating the patient. And so oftentimes, even with the surgery and the polyps come back, symptoms usually are not as severe as they were before. And so if a patient is happy with their quality of life, that's what's really defining whether an intervention is, if you have to get more aggressive with the intervention. Sometimes you do the surgery and the polyps come back incredibly aggressive. And so from a surgical standpoint, we start thinking about what did we miss? What did we do wrong? Oftentimes, as I described that the sinuses are an egg carton, we might not have opened up all of those little partitions. And if you leave any of those partitions around, that's where, in the case of Missy's standpoint, fungus can get trapped and then drive the polyps. And so we look to see if we've done a complete clean out by imaging. And if not, then that's an option to go back and revise the surgery and make sure that we've opened up the cavity widely. And oftentimes that will be, there'll be one area that was missed at the time of surgery. And I'm not saying that it's difficult when you're inside someone's nose to make sure that you're getting all these little divisions out. So it does happen. And that's often a common surgical reason why they come back. Another reason why is patients feel well right after their surgery. You've taken out all their polyps, they're breathing well, and they think that they don't need to keep doing their irrigations. And so they basically fall off their therapy. And that's another reason why the polyps come back. And so the other thing to emphasize here is that the surgery does not replace the other therapies. This is a medical disease and you need to stay on the medications. The surgery is there to improve how the medications get in. So that's basically how we define refractory or recurrent polyps, is basically by symptoms and by endoscopy and by radiology. So moving on, why aren't they responding? Sometimes in rare cases, you can convert a steroid-sensitive polyp to a steroid-resistant polyp, in which case the steroids are no longer effective. But that really is in a small fraction. Another issue with regard to why aren't the steroids working has to do, again, with the delivery. The irrigations are very, very effective. If you're just using the nasal sprays, they're not going to be very effective. The idea behind the irrigations is that when you flood your nose up, say, the right nostril, the fluid comes out the left nostril. And it's that flowing out of the left nostril that is delivering the irrigation, the steroids to the contralateral, the opposite side of the nose. Now, there are some new technologies that have come out recently that take advantage of this idea of flowing in one side, making a U-turn and turning around. And this is something called the EDS, or the exhalation delivery system. And what it does is it takes advantage of some of the anatomy. And what it is it's a powdered steroid spray that you blow into. And when you blow into it, delivers the spray into one side of your nose. By the fact that you're exhaling through your nose, you're closing your soft palate. That's the thing in the back of your mouth that basically swings down and up. And by blowing out, it seals off the nasal cavity from the oral cavity. And when the spray gets to the back of the nose, it has nowhere to go. So it makes a U-turn and it comes out the other nostril. So this is the same type of delivery that we do with the irrigations, but it doesn't require all that volume. And overall, this has demonstrated higher efficacy with regard to deposition of the steroid high up in the nasal cavity to treat the polyps. So that's one option. Now, why do they grow back? And again, we get back to the baseline here, is because there is this underlying inflammatory response. And this has to do with how the body is responding to certain things in the environment. And even if you take the polyps out, shy of wrapping your head in saran wrap, you are going to continue to be exposed to these allergens or fungus that are driving it. Different types of cytokines drive different forms of the inflammation. So the ones that we think about are classic type 2 cytokines of IL-4, IL-5, IL-13. There's also allergen or immunoglobulin E, and these all drive these eosinophils. And so the idea of some of the newer biologics or these designer therapies is to basically block this inflammatory response by designing antibodies that will then bind up all of these inflammatory cascades.
All right. Thank you, Dr. Cohen. We'll go into the next polling question. We're going to talk a little bit about biologics. So let's kick it off with this question. So which of the following best describes how biologics work for treating nasal polyps? And Dr. Cohen described these as designer therapies. So again, biologics are injectables, designer therapies. So option A is they shrink the nasal polyps by blocking allergies. Option B is they control the inflammation within the nasal passages. Option C is they interact with the immune system in the body. Or option D, they eliminate the microbes that cause the nasal polyps. So this one's a little bit of a pop quiz here. Missy, I know you've had some experience with biologics. Can you tell us a little bit about those while people answer?
Yes. So the biologics that I have is a self-injected medication that helps with the nasal polyps. In my case, the biologics did work for me. Now, at first, I was very hesitant. After my polyps return, I did have the option of having a secondary surgery. I didn't want to get the surgery because I knew it would take a period of time for me to heal. And, you know, with small children, that wasn't so much of a good option for me. So I did do my research and I waited a few weeks and then decided to, you know, try the biologics. So after a few weeks of being on the biologics, I noticed right away I got my sense of smell back. I actually smell better than I did after having my first surgery.
Thank you. And so the correct answer for this one is option C. Biologics interact with the immune system in the body. So let's talk a little bit about biologics. Dr. Basso, I know this is your area of expertise, so over to you.
Okay, well, we have right now 3 new biologic treatments that have been FDA approved for CRS, chronic rhinosinusitis with nasal polyps. And there are a number of studies, hundreds of patients have been in these studies showing they're effective and safe. Of course, they can have side effects in a small minority of patients. Dupilumab is one of them. Mepolizumab and omalizumab. Those are the names, the generic names for the medications. And so let's talk about dupilumab first. So dupilumab was FDA approved in 2019 for adults with inadequately controlled nasal polyps. It blocks 2 chemicals that are central to that type 2 pathway, interleukin-4 and interleukin-13. And it requires patients to self-inject every 2 weeks. Usually we show patients how to give themselves self-injections. And once they're competent at it, then we let them do it on their own. And it also is FDA approved, has been FDA approved prior to the nasal polyp approval. It was approved in 2016 for atopic dermatitis or eczema. That is difficult to control, and also difficult asthma came after that, I believe in 2018, moderate to severe asthma that is either corticosteroid dependent on steroids, or moderate to severe asthma that is driven primarily by that type 2 pathway. And recently it was FDA approved for eosinophilic esophagitis. Again, another type 2 inflammatory process. So that's what dupilumab does. It sort of targets that type 2 inflammatory, the central part, you know, of the cascade. There's all these different, spokes that are coming off the center part of the wheel, and so dupilumab does tend to hit a central target. And then mepolizumab was approved after dupilumab for adults with nasal polyps that also do not respond to nasal corticosteroids. This blocks a chemical called interleukin-5, which is actually what stimulates eosinophils to grow and proliferate. So by blocking that, you're reducing these eosinophils, which are a big inflammatory factor in terms of building up the bulk of the polyp. And so this is usually given at home every 4 weeks. Sometimes it can be given in the doctor's office. Some of that may depend on the patient's ability, or sometimes their insurance may dictate where it needs to be given. It's also been approved in the past prior to the nasal polyp approval for severe eosinophilic asthma, a rare condition called Churg-Strauss syndrome, which is a systemic condition that involves inflammation of the small blood vessels in many organs, but asthma and nasal polyps are often a feature of that disease, and a condition called hypereosinophilic syndrome, which is where the eosinophils are astronomically high levels, affecting the bone marrow, the blood, and also infiltrating into certain organs. Omalizumab is that anti-IgE. That's what Dr. Cohen was talking about as the allergic antibody. So what it does is it binds up all that allergic antibody and prevents it from binding to its targets. And by doing that, it reduces the whole inflammatory cascade. So that can be also a very effective medication. It was approved after mepolizumab. And it does have about 1 or 2 in 1,000 patients having systemic allergic reactions. Because of that, there is a black box warning on the package that strongly suggests that this be given in a doctor's office. There can be exceptions made. This is something that would be situational and perhaps between the doctor and the patient, but there is a small risk there. Its side effect profile, however, is quite low. And so it is also approved for moderate to severe asthma. It's been out on the market since 2003. So it is a long-standing medication we've had. It is also used for patients who have these chronic spontaneous hives that keep coming back. And some people say itching is worse than pain. And so that's a condition that maybe will be also potentially comorbid. So what's right for me? Well, the answer is, it's not as straightforward cookbook type situation for every patient getting the same exact therapy. There are more choices now. And Dr. Cohen described the surgery, what the purpose of the surgery is. And he mentioned the new exhale delivery system for the steroid. And we talked about the 3 biologics that are FDA approved now for CRS with nasal polyps. What's right for me? Well, a lot of that's going to be a discussion with your physician, a sort of a shared decision making as to where you go, and you're going to be considering things like, well, what type of side effects are associated with the medications, how much do they cost, how often do they have to be given, are they covered by my insurance, how long do the treatments last, do I do them before surgery or after surgery, et cetera. So this is going to be a little bit different for different patients. And this is where a complete treatment plan that is often better in the more difficult patients being formulated by both the ENT and an allergist immunologist. I find that patients get the best results when they have that combination of a team working for them, because the ENTs may have one perspective and the allergists have a different perspective, but when they talk together about your case, and that's why some of these sinus centers that exist throughout the United States are often giving this coordinated care, which patients like. And again, as I said, type 2 inflammation can be driving other comorbidities. So one of the considerations for which biologic to choose, or whether you go on biologics sooner or later, may be, do you have other conditions beside the polyps? For example, if you have severe asthma and polyps, you may be a candidate for biologics sooner than later. Aspirin-exacerbated respiratory disease, very aggressive inflammatory condition. If you have that, you may be considering that. One of the therapies we didn't talk about for that condition, for AERD, is something called aspirin desensitization, where you give patients gradually increasing doses of aspirin, and you make them become desensitized, but you do that for the purposes of shutting down inflammatory reactions, and that can be a treatment for AERD. So there are different types of therapies for the other comorbidities, but if you have multiple comorbidities, you may get on a biologic sooner than later. So how do I choose a biologic? Does it matter which one? Well, it can matter. Unfortunately, we don't have the perfect markers yet. The markers that we would love to have is something that we could just put in your nose quickly and get a test, a rapid test, where we could say, hey, this is what the profile of inflammation is in this particular patient, and this is what we're going to treat them with, and we would expect that. They have that in oncology and other fields of medicine, and I believe in the next few years we're going to have this. But there are certain tests and tools and laboratory evaluations that can be performed that can give you an idea of which patient might respond to which medication. Also, the comorbidities may give you a clue. So choosing a biologic really depends on some patient-specific processes that are going on. And again, do the patients have other conditions that are specific for example, if you also have chronic hives, you may be a better candidate for omalizumab. And if you have atopic dermatitis, you may be a better candidate for dupilumab. And now I'm going to turn it over to Sanaz.
Thank you, Dr. Basso. So we're wrapping up section 2. We'll do 2 quick Q&A for the panel here before we move on. Dr. Basso, I'm going to stick with you for the first question. So for somebody who has rhinosinusitis that's difficult to control, let's say they're going to their doctor, how would you recommend they talk to their doctor or ask their doctor to be tested for nasal polyps? And I know those go kind of together. So how would you recommend a person dealing with this to go through that conversation?
Okay, well, there's a bunch of things we look at. So I think you want to tell a patient, okay, has it been documented by nasal endoscopy? Have you had a CAT scan of your sinuses to see how diffuse the disease is, how severe your disease is? Is it just a localized form of polyps, or is it involved every sinus is full of polyps? There are going to be different approaches depending on the severity. If you've had surgery, I want to know, what does the tissue cellular pattern show, because that can give us clues. And then there are certain tests like IgE levels and eosinophil counts that can help us. If you have asthma, there's something called an exhaled nitric oxide test that can help with determining which may be the best way to go in terms of what treatment. So I think there are a lot of things you want to look at. And has the doctor done a full workup with lab tests, possibly allergy tests to see if you are strongly allergic, particularly to mold? So allergy tests, blood tests for IgE, eosinophils. If you're an asthmatic, has the doctor measured exhaled nitric oxide? And also, has he looked at the tissue? If you've had sinus surgery, have they looked at to see what type of inflammatory process is going on in the tissue? And again, have they shown you the CAT scan to see what level of polyp problem you have? And if you do need surgery, what is the plan in terms of how to go in and what has to be opened up, et cetera?
That's really helpful. So what I'm hearing is open communication, right? Tell you where they've been, what they've done. Yeah. And we know what other tests can we do from here and where can we go from here? Correct. That might actually play into the next question too. So Dr. Cohen, let's say somebody maybe doesn't want to take the route of surgery. How should somebody dealing with this, a patient, for example, coming to you, maybe talk to you about if surgery isn't for them and they want to consider other options?
Sure. So, this is not cancer. So oftentimes patients come in, they got a cancer, it needs to come out. That's life and death. This is quality of life. And so, this is completely the patient's choice. If they do not, if they get too nervous, they don't want to have the surgery, absolutely. Prior to the biologics, I would say, it's like, okay, we keep doing what we do. We're going to give you rounds of prednisone. If there's an infection, we're going to treat you with antibiotics, and we will conservatively manage it. To be honest with you, at this stage of the game, the recommendations are the biologics come in after surgery, give surgery a chance first. I might kick it back over to Dr. Basso to get his reflections on whether biologics have a role in place of surgery. Because right now, the way that the field is thinking about it, it's for the patients that fail surgery. And we still believe that the surgery is a good route. It's a very safe route. But starting off with a biologic is a theoretical. I don't necessarily know if it's a practical option based on insurance companies and non-medical biology, but more economic issues. I'll leave it at that.
Yeah, I mean, I agree that there are certainly economic issues. That they have extreme costs, and so a lot of the payers are really not going to be considering approving a biologic unless you've gone through at least one good surgery and failed. Look, I can make a suggestion. If you're going to have surgery, go to someone who does a lot of sinus surgery, and we have surgeons that are doing only sinus related surgery, and those probably are going to give you the best outcomes. It's like everything else, Noam is a phenomenal surgeon, Dr. Cohen, and he works with a number of people who really introduced the technique into the United States. So what's important is that you find yourself a good surgeon. And the other thing that is, find yourself a good surgeon who's willing to work with your allergist to coordinate a program. Now, there are some situations, Dr. Cohen, though, where maybe surgery might take a backseat to the biologic in terms of order. And that, I think, would be when there's a strong comorbidity, for example, of a severe asthmatic. So if the asthma is so severe that you're not even going to be worrying about even having that patient go to surgery, then you may need to use it in the situation where you need the asthma calmed down before considering a surgical procedure. So I always say, if there's a more severe condition, quality of life is a big issue with polyps, but asthma can be potentially life-threatening. So I think that needs to be considered too. And also, there may be situations where patients are just not good candidates for surgery, and that might be another situation where you may want to go with a biologic before surgery. But for the most part, the lion's share of patients who do not respond to simple topical nasal corticosteroids up front will end up needing a sinus surgery. Get yourself a really good sinus surgeon who will coordinate with someone who will be following you with medical therapy, and you have a better chance of having good outcome. That being said, there's still going to be some people who, even with the best coordination, are going to have such aggressive inflammatory disease that they're going to need a biologic, and that's what they're there for. And we do use them in those patients, and that's the appropriate. I believe that's the appropriate way to approach this situation.
Thank you both. What I hear is that there's no cookie cutter solution here. So definitely work with your doctor for your individual plan. And Dr. Cohen, I hear you're an amazing surgeon, so I'm coming to you if I need it. We've got about 6 minutes left, so we're going to run through this third and final section a little bit quickly here, but let's talk a little bit about how you can be engaged to make sure that your treatment is optimal for you. So looking at getting involved in your treatment, as you've heard over this program, there's a lot of different options, right? There's surgery, there's biologics, so there's other treatment options. And the point really here is that you can help make decisions that are best for your life. And so we call this shared decision making, which means that you should be talking with your doctor, asking them the right questions. Here are some example questions you can ask on the slides here, but asking them the right questions and turning it into a two-way conversation. And that can really help with making sure that the treatment plan or management plan that they come up with is customized for you. Missy, I know you've had some different approaches to treatment decisions. Can you just tell us briefly about some of the questions you've had or decisions you've helped make to make sure that the treatments were right for you?
Yes. So within my circumstance, and I tell everyone, it is definitely important to get involved with your treatment because you're the only one that knows your body and your circumstance. So a doctor can, basically tell you what is best, but if you're not letting your doctor know your circumstance, they're unable to assist you with the best treatment option. Like for instance, in my situation with having children and having to work to take care of home, I had to have, those options with my doctor to determine what was the best treatment for me. Again, I didn't want to opt into a second surgery because of my particular circumstance. So when my doctor offered me the biologic option because of my circumstance, that worked best for me. Also pertaining to joining multiple groups, speaking with other individuals that have, the comorbid issues as me, and also nasal polyps, also allowed me more broader insight as to what questions I should also ask my doctor. A lot of individuals I spoke with, they said it could be their diet. So, speaking to my doctor and asking questions, is it pertaining to the diet as well? Also with allergies, getting that immunotherapy treatment, also aids into assisting with helping with the issue with your nasal polyps. So having those multiple groups involved would definitely assist with, managing your nasal polyps.
Yeah, so there's the question about, is it safe and effective for me? But also, is it practical for my circumstances? So like you mentioned, is it going to mesh with my life? Is it going to mesh with my childcare, my work needs, all of that? So take that all to your doctor and make sure you're having that conversation. It's got to be two ways. It can't just be the doctor telling you what to do, but you kind of pitching in and saying, this is what may or may not work for my circumstance. So let's hear a little bit, again, from Jack about his involvement in his treatment decisions.
It is important to me to be involved in those decisions, especially as I've gotten older, and things like surgeries, come with several week recovery times and things that are going to impact my availability for school and work and sports and stuff like that. It's definitely important to me that I kind of have the final say on that stuff, since it's my body that's going to be experiencing the, side effects of whatever I go through. And I have appreciated that about my last couple of doctors that have certainly taken, my life outside of the surgery into consideration, or other treatments that we've tried.
All right. So part of the people who should be having this conversation with you, obviously you're in the middle of this care team, but here's some of the folks you might be working with. So either an allergist or an immunologist. A lot of times these will be specialist doctors who will help diagnose you and manage your nasal polyps. And if you have asthma, that asthma as well. In some cases, it'll be your otolaryngologist. These are commonly known as ear, nose, and throat, or ENT doctors, as you may have heard. They're often the ones that perform the nasal endoscopies, the biopsies, and the sinus surgery. In some cases, you might be seeing a pulmonologist. These are, again, specialist doctors, and they help manage respiratory comorbidities or conditions such as asthma as well. And in a lot of cases, you'll be working with nurse practitioners or physician's assistants as well. So obviously, nasal polyps is a complex condition, and you need a kind of a whole care team as well. We're going to jump over to, I believe, our last polling question. So now that you've listened to this program, how likely are you to consider initiating a biologic for nasal polyps? So again, biologics are those injectable design therapies. Option A is extremely likely. Option B is very likely. Option C is somewhat likely. Option D is not very likely. And option E is not likely at all. Missy, let's come to you. I know you've been through this conversation. So what do you think about this?
With me, extremely likely. It fits within my circumstance, and I'm going to continue taking the biologics because it's working. It's working for my circumstances. Yes, I do have the type 2 inflammation, so it fits right into my criteria.
Perfect. So just wrapping up, I know we're right at time, so we're going to roll through these last few slides. We talked about this, but make sure you're expressing your needs and expectations. You have to be clear. You have to communicate clearly with your care team. All of those folks who mentioned, your allergist, your ENT, everyone, talk about what you expect and what's not working for you. They're not going to be able to read your mind, so just talk it through. Express your expectations, expect to be heard. Again, talk about the practicality of any treatment options for you specifically. And then wrapping it up, there are ways to know if the treatment isn't working. And I'm going to kick it over to the doctors for this one, because I know this comes up, right? There's a lot of trial and error with nasal polyps treatments. But can you guys talk about some of these questions or things you'll look at to know if something's not working?
Well, John, you want to take lead?
Sure. So, I mean, we usually, for surgery, I'll let you talk about surgery, but in terms of biologics, I mean, patients may start responding within 1 to 2 months, and we like to see that. But the truth is that the time that I'm going to make a decision about whether it's really working is somewhere in the 4 to 6 month range. So if it hasn't started really kicking, if the patients don't have an objective finding, something that we can say for sure has improved while that patient's been on a biologic, the size of the polyp, the improvement in the sense of smell, congestion, et cetera. If we don't see objective changes within 4 to 6 months, then I think we're going to conclude that that patient's not responding to that particular biologic.
And from the surgical standpoint, it's the exact opposite. So when we go in and we remove all the polyps, we're expecting them to do exceptionally well right after the surgery, right after the packing. Yes, that first visit back is rough as we clear everything out. What I usually tell my patients is the first indication that the polyps are coming back is when you start losing your sense of smell again, when the coffee doesn't smell right. Before you get the nasal obstruction, before you start getting the pressure, the first indication that the polyps are coming back is decreased or lost a sense of smell. And usually when patients will call me up, I'll see them and you can start seeing the polyps forming in the roof of the nose. While they're still small, we still have a shot of reducing them just with aggressive anti-inflammatory medication. So whether it's the steroids, but putting your head in different positions so that it pulls at the roof of the nose, getting your head upside down, that is often effective, or doing a short round of prednisone to try to decrease it. But it's the exact opposite of the biologics, where you're waiting for it to shrink down. When we do surgery, you're starting at 0 and they're growing back. And again, the time frame is anywhere from 3 months outwards to years. They can be pretty good for a while, and then if they get exposed to some environmental trigger, it can actually, let's say, a flood and some mold. All of a sudden, they're fine for years, and then the polyps come right back after a mold exposure.
Awesome. Thank you. So where can you find support? Start with obviously your doctor, your nurses, your care team, but additional support. The Asthma and Allergy Foundation of America does have an online community. It is led by our team members here at AAFA, but also peers. So people who've been through a lot of these similar situations. So if you just need, a listening ear, or if you just want to talk to somebody who's been through the same situations or talk with AAFA staff, please feel free to join. And that URL is on the slide right there. I know we're a little over time, so Dr. Cohen and Dr. Bosa, I'm going to ask you for some brief answers to some final Q&A. Let's go with this one question. If you've failed every treatment and are forced to live with nasal polyps, how concerned should we be with the chance of polyps developing into cancer? Can they be left indefinitely if you can stand the quality of life? So this is a question about the link to cancer, and then Can you just deal with them if you have to?
So oftentimes patients hear the word polyp and they think that it's a precancerous lesion because of what's going on in the gut. Inflammatory polyps are not precancerous. That being said, if it's one-sided, if there's bleeding associated, there are entities in the nose where a cancer can induce or a polyp can be cancerous. So if it's one-sided, if there's bleeding, if there's symptoms of pain, that's something that you don't want to blow off. If they're on both sides and it's just congestion and it's been pretty static, you do not need to worry that these are going to degenerate into cancer. It's relatively easy for an otolaryngologist to biopsy these polyps in the clinic to rule out cancer. Doesn't mean that if you get the front of the polyp, there's not cancer hiding behind it. But again, if it's on both sides, chances of it being cancer is incredibly low. One-sided, bleeding, pain, that's more concerning.
That's really helpful. Thank you. And last question over to you, Dr. Bosa. You mentioned some people may not be candidates for surgery. Who are those people, or how do you determine whether they're not candidates?
I think that depends primarily on their underlying medical conditions. I mean, if they have severe asthma, they may be candidate for surgery after the asthma is controlled. That's a fixable condition. But I'm talking about patients who have just very severe medical conditions, heart conditions, or transplant patients, or patients who have certain cancers, et cetera. So, that's something that your medical doctor may have to determine as to whether you're a good candidate for undergoing general anesthesia. And, obviously very, very elderly patients who have multiple medical conditions would be the people I'm worried about the most.
Thank you. And before we wrap up, I think one topic we didn't touch on today was clinical trials. So there's obviously a lot of movement happening in this space just with potential new treatments. So I will mention if you think you might be a candidate or you're interested about learning about clinical trials, definitely talk to your doctor, see if they've heard of any clinical trials or even if they're an investigator in one in your area. If not, you can look at clinicaltrials.gov, or you can reach out to patient advocacy organizations like the Asthma and Allergy Foundation of America, and we can help direct you to potential clinical trial opportunities that will, get you enrolled in some sort of research for potentially new treatments as well. So those are great places to go for resources also. And with that, I think let's go ahead and wrap up. Dr. Basso, Dr. Cohen, and Missy, I want to thank you guys for spending your morning with us before we let you go for your next cup of morning coffee. We want to thank Regeneron and Sanofi for their support of this program. A reminder that for the participants here, that there's a post-program questionnaire, and you can use that to get your participation certificate. The slides are also available on demand, as is the program available on demand. So you can download those slides and watch this program on demand. And with that, thank you guys for joining our program today.